Assalamu alaikum. I'm Professor Shamsud Jaman, Professor of Pathology. I invite all of you in my today's fourth lecture on hematology. Respected audience, you know, in the third lecture I have told about iron deficiency anemia, one type of microcytic hypochromic anemia, that is iron deficiency anemia, briefly. Today I will discuss about macrocytic anemia. Now come to macrocytic anemia. First we have to know what is macrocytic anemia. Anemia in which mean corpuscular volume of RBC is increased, that anemia is called macrocytic anemia. Anemia in which mean corpuscular volume is increased, that anemia is called macrocytic anemia. So in microcytic hypochromic anemia, RBC is reduced in size. In a macrocytic anemia, RBC size is increased. So if the normal size of RBC and if the smaller size, this is called hypochromic, microcytic hypochromic. If the size is increased like this is called, by definition, this is macrocytic anemia. Dear audience, now come to what are the causes of macrocytic anemia. First, now come to causes of macrocytic anemia. And we can say what are the causes of macrocytosis. All the same, first come to causes. What are the causes? The causes may be folic acid deficiency, then vitamin B12 deficiency, then hemolytic anemia, post hemorrhagic anemia, other causes of macrocytic anemia: liver disease, alcoholism, fish tapeworm infestation. Fish tapeworm infestation. So liver disease, alcoholism, fish tapeworm infestation, and also scurvy, that is deficiency of vitamin C related disease, etc. So these are the different important causes of macrocytic anemia. Now come to types or classification of macrocytic anemia. Types of macrocytic anemia. Macrocytic anemia is two types. One is macrocytic normoblastic anemia. Macrocytic normoblastic anemia, and another is macrocytic megaloblastic anemia. Macrocytic megaloblastic anemia. Megaloblastic anemia. So type is macrocytic normoblastic and macrocytic megaloblastic. Students, what we mean about macrocytic normoblastic anemia? In case of macrocytic normoblastic anemia, in macrocytic normoblastic anemia, if we consider this blood, in blood we will get macrocyte, and if it is bone marrow, If it is bone marrow, in case of macrocytic normoblastic anemia, we will get the normoblast. We will get the normoblast. What it means, you know, during erythropoiesis, we get a lot of stages. And during erythropoiesis, the nucleated red cell, which is normal in size, normally developing, and normally undergo maturation, that nucleated red cell is called normoblast. So in case of macrocytic anemia, in the blood we will get macrocyte, and in the bone marrow we will get normoblast. So it is called macrocytic normoblastic anemia. So in case of macrocytic megaloblastic anemia, in case of macrocytic megaloblastic anemia, what we will get? In the peripheral, in the blood, again we will get macrocyte. Again we will get macrocyte in the blood. But in the bone marrow, we don't get normoblast, we get the megaloblast. We get megaloblast. Megaloblast is nothing but nucleated red cell, but the size is abnormally large, and it is abnormal functioning, abnormal characteristics, and there is maturation arrest. So it is called megaloblast. So in case of macrocytic megaloblastic anemia, we will get macrocyte in blood, and in bone marrow we will get the megaloblast. So in both cases we get macrocyte in peripheral blood. Now come to macrocytic megaloblastic anemia. Macrocytic megaloblastic anemia. Again, we recall macrocytic megaloblastic anemia means there is macrocyte in the peripheral blood, but megaloblast in the bone marrow. Briefly, this anemia is simply known as megaloblastic anemia. It is simply known as megaloblastic anemia. So now come to megaloblastic anemia. What are the causes of megaloblastic anemia first? Now come to causes of megaloblastic anemia. Now we're talking about the causes of megaloblastic anemia only. So causes may be, one is folic acid deficiency, and another is vitamin B12 deficiency. Vitamin B12 deficiency. These are the causes of megaloblastic anemia, or that is causes of macrocytic megaloblastic anemia. Now come to, if there is deficiency of either these two or both, how megaloblastic anemia develops. That is, what is the role of vitamin B12 and folic acid to prevent megaloblastic anemia, or how deficiency of these two or one of them causes megaloblastic anemia, that is pathogenesis. You know, folic acid and vitamin B12 both are maturation factor. Both are maturation factor. Dear audience, you know, during erythropoiesis, what happens? We get a lot of stages, ultimately mature RBC. And from the erythroblast, we get nucleated red cell, and there is nucleated red cell, ultimately the maturation of nucleus, maturation of the cytoplasm, and we get the mature RBC. And this maturation is carried out by this maturation factor. If there is deficiency of this maturation factor, what will happen? In the erythropoiesis, there will be maturation arrest. So maturation arrest of RBC in the stages of erythropoiesis due to deficiency of this maturation factor. Due to maturation arrest, we get megaloblast. We get megaloblast like this. Due to maturation arrest, we get macrocyte in the peripheral blood. Now come to, if anybody suffers from megaloblastic anemia, how megaloblastic anemia can be diagnosed in laboratory. That is now come to laboratory diagnosis of megaloblastic anemia. Megaloblastic diagnosis. Before that, we have to know in our context, which one is more common deficiency, either folic acid deficiency or vitamin B12 deficiency. In our context, folic acid deficiency is more common than vitamin B12. Why? Before that, we have to know why folic acid deficiency is common than deficiency of vitamin B12. Why? The answer is like that. Number one, vitamin B12 source is animal. In our context, in our daily intake of food, the amount of animal food is insufficient. What I want to mean, as vitamin B12 source is animal, so amount of animal food in our daily intake, of food, a bit insufficient. As animal food a bit is insufficient in our daily intake of food, we have to depend on folic acid. So we have to depend on folic acid. So we have to depend on folic acid. But you know, folic acid source is vegetable. But folic acid source is vegetable. As folic acid source is vegetable, and as folic acid is water soluble vitamin, it is water soluble vitamin. As it is water soluble vitamin, the folic acid is lost from our vegetable. Folic acid is lost during cutting, during washing, and during cooking of vegetables. So dear audience, instead of animal, we have to take folic acid from the vegetable source. Unfortunately, as it is water soluble, during cutting, during washing, during cooking, in our context, the folic acid is lost from the vegetable. So folic acid deficiency is more common. So folic acid deficiency is more common than vitamin B12. Another one cause, the first cause of why folic acid deficiency is common than vitamin B12, like this. The second cause is when there is deficiency of vitamin B12. When there is deficiency of vitamin B12, you know, folic acid and vitamin B12 both remain stored in liver. So during deficiency of vitamin B12, the storage form of vitamin B12 from the liver try to compensate the deficiency. And when there is deficiency of vitamin B12, the storage of vitamin B12 in liver is exhausted within 2 years. Within 2 years, the storage is exhausted if there is deficiency of vitamin B12. But when deficiency of folic acid, the liver storage of folic acid is exhausted within 6 months. The storage of folic acid in liver is exhausted within 6 months. So, when deficiency of vitamin B12, exhaustion requires 2 years, but when deficiency of folic acid, exhaustion requires 6 months. So, folic acid deficiency is more common than vitamin B12 in our context. Now come to laboratory diagnosis of megaloblastic anemia. Dear audience, I have told you in megaloblastic anemia, macrocyte is found in blood and megaloblast is found in bone marrow. So now come to laboratory diagnosis of megaloblastic anemia. Number 1, we have to do blood examination. Then biochemical test. Then bone marrow examination, and then Schilling test. So, how to diagnose megaloblastic anemia in laboratory? Blood examination, biochemical test, bone marrow examination, Schilling test. Now come to bone marrow examination, blood examination first. First, we have to do hemoglobin estimation. It will be decreased. That is, the patient is anemic. Then we have to do MCV, mean corpuscular volume. It will be increased. So it is macrocytic anemia as MCV is increased. Then we have to do total leukocyte count. It will be normal, or in later stage it may be decreased. That is leukopenia. So in early stage it is normal, in later stage it may decrease. That is a bit leukopenia. Then differential leukocyte count, that is DLC, normal distribution. Then we have to do peripheral blood film. It is important, peripheral blood film. I have told you in the third lecture, in peripheral blood film, we have to search RBC series, WBC series and platelet. Now come to RBC series in megaloblastic anemia. RBC series in megaloblastic anemia. Here what we'll get in case of microcytic hypochromic anemia, we have got microcyte, smaller size RBC. Here we'll get RBC series show macrocyte and macroovalocyte. That is, in the peripheral blood we'll get RBC large size macrocyte and also macroovalocyte. In addition to this, in the RBC series we can get nucleated red cell and inclusion bodies like Howell-Jolly body. So in addition to microcyte and macrocyte and macroovelocyte, we can get nucleated red cell and inclusion body like Howell-Jolly body. Howell-Jolly body may be present. So important findings of megaloblastic anemia in RBC series: macrocyte and macroovelocyte. In addition, you can get nucleated red cell and also inclusion body like Howell-Jolly body. Now come to WBC series in peripheral blood film. WBC series in peripheral blood film. The cells of WBC series show normal count or a bit decreased, but there is giant metamyelocyte. WBC series cells show hypersegmented neutrophil. So WBC series cells show hypersegmented neutrophil. What is this? Dear audience, you know, if it is neutrophil, we get 2 to 3 lobes, usually 3 lobes, neutrophil. If neutrophil containing more than 5 lobes, then it's called hypersegmented neutrophil. It is a characteristic feature of megaloblastic anemia in peripheral blood. This hypersegmented neutrophil is also called macropolycyte. It is also called macropolycyte. So hypersegmented neutrophil or macropolycyte is a characteristic feature in WBC series in peripheral blood of megaloblastic anemia. Then come to platelet. Platelet usually adequate in number, but may be decreased in later stage. Usually adequate or may be decreased. So this is the peripheral blood film findings of megaloblastic anemia, or that is macrocytic megaloblastic anemia. Now come to biochemical test. Biochemical test. That audience, we know folic acid deficiency or vitamin B12 deficiency is the cause of macrocytic megaloblastic anemia, is the cause of megaloblastic anemia. So we have to assay folic acid and vitamin B12 in plasma. So plasma assay of folic acid and vitamin B12. If we get decreased folic acid level in plasma, so cause of megaloblastic anemia is folic acid deficiency. If we get vitamin B12 reduced in amount in the plasma, the cause of megaloblastic anemia is vitamin B12 deficiency. If there is vitamin B12 deficiency, then we have to do Schilling test. If we get vitamin deficiency by estimating or by assaying vitamin B12 in blood, then there is question of Schilling test, otherwise not. Again, we recall, when there is vitamin B12 deficiency, we have to go for the Schilling test. Then bone marrow examination. If we do bone marrow in case of megaloblastic anemia, what we will get? Dear audience, you know, in bone marrow we see the cellularity, we see the myeloid erythroid ratio, we see the erythropoiesis, we see the granulopoiesis, we see the megakaryocytes, etc. And what will be the findings of bone marrow in megaloblastic anemia? Marrow is hypercellular with decreased myeloid erythroid ratio. So marrow is hypercellular with decreased myeloid erythroid ratio. Then erythropoiesis show megaloblastic hypercellularity. So erythropoiesis show megaloblastic hypercellularity. Then granulopoiesis show giant metamyelocyte, and megakaryocyte seen adequate number or maybe decreased in number. So megakaryocyte seen adequate in number or maybe decreased in number. So this is the bone marrow findings. Marrow is hypercellular with decreased myeloid erythroid ratio. Erythropoiesis show megaloblastic hypercellularity. Granulopoiesis show giant metamyelocyte. Megakaryocyte seen adequate in number or maybe decreased. Dear audience, now come to as there is hypercellularity of the erythropoiesis, that is, as there is a hypercellular erythropoiesis, so there is hypercellular bone marrow. Due to hypercellularity of RBC series, marrow is hypercellular. Dear audience, you know erythropoiesis here RBC series or RBC is developed. And other than RBC, all cells in the bone marrow is called myeloid series. So only RBC series is called erythroid series. Other than RBC, all cells together called myeloid series. As there is hypercellularity of the erythropoiesis, so there is decreased myeloid erythroid ratio. As there is hypercellularity of the erythropoiesis, so there is decreased myeloid erythroid ratio. Now come to, as we know, folic acid or vitamin B12, these are the maturation factor. As there is deficiency of folic acid or vitamin B12, there is deficiency of maturation factor. As there is maturation factor deficiency, so there is macrocyte formation in the blood and there is megaloblast in the bone marrow. Dear audience, you know, in granulopoiesis, a lot of stages in granulopoiesis. One of the steps of granulopoiesis is myelocyte, and from myelocyte, metamyelocyte, and then myelocyte. So metamyelocyte and myelocyte, these are the metamyelocyte, these are the stages of granulopoiesis, and for its maturation, it needs folic acid and vitamin B12. If there is deficiency of this, there is maturation arrest, so there is development of giant metamyelocyte, not the usual size of myelocyte, rather giant metamyelocyte. So this is all about the bone marrow findings. Now come to, if we get vitamin B12 deficiency by assaying vitamin B12 in plasma, then there is question of Schilling test. Suppose it is a case of vitamin B12 deficiency, then we have to do Schilling test. Now come to Schilling test. Dear audience, there is two phases of Schilling test. There are two phases of Schilling Test. Phase 1 and phase 2. Now come to first phase 1. What we do in phase 1? The patient suspected with vitamin B12 deficiency is advised for overnight fasting. So patient should come after overnight fasting. So patient should come after overnight fasting. Then patient is to take in 1 microgram radio-labeled vitamin B12 in 1 glass of water. Patient should ingest ingestion of 1 microgram radio-labeled vitamin B12 in 1 glass of water. 1 glass of water. So if is glass water and here 1 microgram, radio-labeled vitamin B12 is given. Then patient is to taken orally. After taking orally 1 microgram vitamin B12 radio-labeled, taking orally, then 1000 microgram plain vitamin B12 is given intramuscularly. So after taking 1 microgram radio-labeled vitamin B12 in 1 glass of water orally, the patient is to be injected intramuscularly 1000 microgram plain vitamin B12. So this radio-label will be absorbed from the intestine, and from the muscle it will be absorbed plain vitamin B12. It is given intramuscularly to flush this radio-labeled vitamin B12 in urine. Why it is given? It is given to flush this radio-labeled vitamin B12 from blood in urine. Then 24 hours urine is collected. Then 24 hours urine of the patient is collected to estimate. 24 hours urine of the patient is collected to estimate urinary excretion of radio-labeled vitamin B12. Then what is again, after overnight fasting, patient is to come here in the laboratory, and 1 microgram radio-labeled vitamin B12 in 1 glass of water, patient is to take orally. After taking orally, patient is injected intramuscularly 1000 microgram plain vitamin B12 to allow or to flush the radio-labeled vitamin B12 in urine. Then after 24 hours urine of that patient is collected to estimate urinary excretion of the radio-labeled vitamin B12. Now come the interpretation of the first phase. Interpretation first phase. Nowadays, you know, if this is the stomach, you know, is the intestine like this. You know, vitamin B12 when comes in stomach, from the stomach there is secretion of intrinsic factor of calcium. Nowadays, the combined form of intrinsic factor of calcium and vitamin B12 comes in the intestine, and there is a receptor for this intrinsic factor of calcium. Then due to presence of receptor, vitamin B12 is absorbed in blood. This is normal physiology, normal pathway of absorption of vitamin B12. Now come to interpretation. If excretion of radio-labeled vitamin B12 in urine, excretion of radio-labeled vitamin B12 in urine 10% or more than 10%. What I say, if the radiolabeled vitamin B12 that was taken orally, of this 1 microgram, if 10% or more than 10% of radiolabeled vitamin B12 is excreted in urine, we say patient is normal. It is normal. That is, no defect in the stomach, no defect in the intestine. It is normal. If excretion of radiolabeled vitamin B12 is less than 5%, if less than 5%, what is the interpretation? The interpretation is defect is either in stomach or in intestine. So if excretion is less than 5%, defect is in either stomach or in intestine. So if there is defect in the stomach, there is insufficient inducing factor of Cassel. If insufficient inducing factor of Cassel, we have taken orally vitamin B12 radiolabeled, it will be absorbed. So there will be less than 5%. Again, if stomach is okay and there is defect in the intestine, again the combination will come. Due to absence of receptor, it will be absorbed. So excretion will be less than 5%. So if excretion is less than 5% of the radiolabeled vitamin B12, it indicates the defect either in the stomach or in the intestine. Then to know where is the defect, we have to do the second phase. Now come to second phase. If excretion less than 5%, we have to go for the second phase. Second phase of or phase 2 of Schilling Test. Again, patient is to keep overnight fasting. Again, overnight fasting, and after overnight fasting, patient is given orally again 1 microgram radiolabeled vitamin B12 in 1 glass of water, in addition to some intrinsic factor of Cassel. What you do, 1 microgram radiolabeled vitamin B12 plus intrinsic factor of Cassel in 1 glass of water. So 1 microgram radiolabeled vitamin B12 plus intrinsic factor of Cassel is taken orally. After that, again 1000 microgram plain vitamin B12 is injected intramuscularly. Again to flush this radiolabeled vitamin B12 in urine. After that, again 24 hours, urine is collected to know or to estimate excretion of radiolabeled vitamin B12. So after overnight fasting, again 1 microgram radiolabeled vitamin B12 along with intrinsic factor of Cassel is given orally. Then again, like before, 1000 microgram plain vitamin B12 is injected intramuscularly. After 24 hours, urine is collected to estimate the radiolabeled vitamin B12. Now come the interpretation. If excretion is more than 5%, there is excretion was less than 5%. After giving intrinsic factor of Cassel, if excretion is more than 5%, what it means? If this is the stomach, after giving intrinsic factor of K cell, if excretion is more than 5%, what it indicates? It indicates defect in stomach. It indicates defect in stomach. That is, as there is defect in stomach, there is no sufficient intrinsic factor of K cell here. So after giving intrinsic factor of K cell, the excretion is created. So defect is in the stomach. Now come to, if excretion is like before, is less than 5% again. If excretion is again less than 5% after giving intrinsic factor of K cell, it indicates stomach was okay. There was intrinsic factor of K cell, but there is receptor defect in the intestine. There is no receptor or insufficient receptor. So the combined form of vitamin B12 intrinsic factor of K cell come here, but there is no absorption. So if again less than 5% excretion, it indicates excretion in the defect in the intestine. So this is the Schilling test. By doing Schilling test, we can know whether it is defect in the stomach or in the intestine. Dear audience, now come to one thing. If anybody suffers from gastric carcinoma or chronic atrophic gastritis either gastric carcinoma or chronic atrophic gastritis, in both cases there will be diminished intrinsic factor of K cell. So in gastric carcinoma or in chronic atrophic gastritis, in both cases there will be decreased intrinsic factor of K cell secretion from the parietal cells of gastric gland. In that case, there will be less absorption of vitamin B12 and it will lead to megaloblastic anemia. So the megaloblastic anemia in which the cause is in the stomach, that type of megaloblastic anemia is called pernicious anemia. Again, if the cause of megaloblastic anemia is within the stomach, either gastric carcinoma or chronic atrophic gastritis, that type of megaloblastic anemia is called pernicious anemia. So all pernicious anemia is megaloblastic anemia, but all megaloblastic anemia is not pernicious anemia. Dear audience, now come to how can we know in megaloblast in bone marrow. Now come to how can we know megaloblast in bone marrow. There is the characteristics of megaloblast. Large cell. So this is abnormally large cell. Then thin bluish cytoplasm. Then large nucleus. So due to large nucleus, there is thin bluish cytoplasm. So this is nucleus and thin bluish cytoplasm. Like this. And the characteristics: asynchronous nuclear and cytoplasmic maturation. What it means? You know, during development of RBC, a nucleated red cell like this, nucleus, red cell, then there is development of a smaller nucleus or pigmented nucleus, and there is appearance of hemoglobin. Ultimately, there is exclusion of the nucleus comes out, and the RBC is filled with complete hemoglobinization. This is mature RBC. This is the maturation. All maturation is carried by the vitamin B12 and folic acid. So if there is deficiency of this, there will be maturation arrest. So there is an asynchronous nuclear and cytoplasmic maturation. Again, during maturation, nuclear maturation and circular maturation run parallel. If there is deficiency, it will not parallel. So there is asynchronous nuclear and cytoplasmic maturation. Dear audience, again, during maturation of RBC, the nucleus, within the nucleus, if the RBC is a nucleus, the chromatin become clamped. Chromatin became clamped, so the nucleus becomes smaller in size due to clamping of the chromatin. But in case of megaloblast, as there is maturation arrest, the chromatin remain fine and dispersed. And this fine and dispersed chromatin within nucleus indicates maturation failure. Another is fine and dispersed chromatin. Normally, the chromatin clamps and there is pignotic nucleus. But as there is deficiency of maturation arrest, there will be no maturation or delayed maturation of the nucleus. So there will be fine and dispersed chromatin in the nucleus, and it indicates maturation failure. Dear audience, this is all about the megaloblast, and this is all about the megaloblastic anemia. Today up to this, thanks all.